Chapter 9, Epidemiological Application, Sandra Monk. The objectives today, we're going to define epidemiology and describe how it's developed over time, and then describe the essential elements of epidemiology and an epidemiological approach. We're going to discuss the steps of the epidemiologic process and explain basic concepts related to populations at risk, natural history of diseases, level of prevention, host-agent environmental relationships, and the web of causation model. And then we're going to look at and provide some examples of how nurses use epidemiology in their community health practice. Some definitions. Epidemiology is the study of the distribution and factors that determine health-related states or events in a population, and the use of this information to control health problems. The purpose of epidemiology is to study populations to determine the causes of health and diseases within the population, monitor the health of the population, identify determinants of health and disease within communities, and then also to investigate and evaluate interventions to prevent disease, to maintain health. Florence Nightingale, as a nurse epidemiologist, she demonstrated that epidemiology, through a safer environment, resulted in a decreased mortality rate. And this was during the Crimean War, when she, studied about environment, fresh air, fresh water, clean dressings, and ample supplies could help reduce and did reduce the death rate. Other history related to epidemiology: Louis Pasteur developed pasteurization. It was not new to the 19th century. It goes all the way back to the 4th century BC, when Hippocrates was the first person to use ideas which are now epidemiology, to actually investigate and look for sources of disease. Joseph Lister, he discovered and developed antiseptic surgery. Think about Listerine. Robert Koch developed pure cultures and identified organisms that cause TB, anthrax, and cholera. And John Snow is known as the father of epidemiology, and he was found that a single water pump in a village was contributing to a cholera outbreak, and developed an outbreak map to determine, to demonstrate his findings. In the 20th century, now we've began to shift from looking at single agents to determining multifactorial etiology. So maybe humidity and bacteria have something to do with a disease outbreak. Maybe certain times of the year, certain geographical areas have something to do with an organism. The development of genetic and molecular techniques have become more prevalent. There are new infectious diseases, and old infectious diseases are changing. And then the public health preparedness for bioterrorism, as we've seen since the onset of September the 11th. We've begun to think more about bioterrorism being a risk for United States and global citizens. How nurses use epidemiology: nurses will look at the health and disease causation and how to both prevent and treat illness. Nurses are involved in public health, home health, even in hospitals, doctors' offices. Nurses are involved in the surveillance and monitoring of disease trends in homes, schools, workplaces, and clinics. Nurses will, and what happens is nurses will be probably the first ones to evaluate the number of clients that are presenting with a similar disease. So, for example, in school, we notice that, a number of children, have flu or upper respiratory, outbreaks, or hand, foot, mouth disease in a daycare center, something similar like that. And so that an investigation can be done to see if there is some single source, if there are multiple sources, and things that can be done to prevent the spread of disease. Some basic concepts: we look at rates, proportions, risk ratio when determining epidemiology. Is this something that is a widespread problem, or is it something that is limited to a certain area? We look at measures of morbidity and mortality, how much illnesses is caused and disease, and how much has it contributed to the death count, or to death rates. Measures of incidence, and then the numbers, and then the prevalence, and then we look and see if it is an epidemic. That it's much larger than just a few isolated or single episodes. And epidemiological studies are done to look for all the various factors that lead to a diagnosis. You want to find a diagnosis so that you can prevent and so that you can treat. More basic concepts, the epidemiological triangle, we talked about that some last week. We said it is the agent, the host, and the environment, and changes in one of these elements can influence the occurrence of disease by increasing or decreasing a person's risk to the disease, which we hope to decrease a person's risk for the disease. The web of causality, the associations are sometimes mutual with lines of causality going in both directions. And the epidemiologist may be looking for results at a local level, and if so, they would measure related to causality, they would measure local subjects, and if it was a national health problem, then a national sample would be chosen. The level of preventive interventions, this is one thing that would really impress on you in this semester. And primary interventions seek to promote health and prevent occurrence of disease, so that is prevention. Secondary intervention seeks to detect disease early, so these are your screenings, before clinical signs and symptoms become apparent in order to make that early diagnosis and to begin treatment. And then tertiary I always think about this as rehabilitation of disability, limitation, and rehabilitation from disease and injury and disability. So primary is prevention, secondary is screening, and tertiary is looking at those at the rehabilitation. Screening involves testing of groups of individuals who are at risk for a specific condition but do not have the symptoms yet, and the goal is to determine the likelihood that these individuals will develop the disease. Screening test is not a diagnostic test. It is simply a screening test. Mammograms are a screening test. You do not have you're not diagnosed with breast cancer until there has actually been a biopsy, and sometimes even additional surgeries to complete the staging process. So screening is not a diagnostic process. Colorectal screening is not a diagnostic process. However, it does does indicate that the person has blood in their stool from their colon, and that possibly there's some potential for some polyps or even greater disease. So effective screening programs must include referrals. So you've got to know what you're going to do. If people have the likelihood of the disease, they've got to be referred for diagnostic evaluation for those who screen positive to determine if they actually have the disease and need the treatment. So that's part of the screening process. And one kind of concept, from this screening is, if I, as a community nurse, if I do a good job with my screening, and I, reach a large group of people and the right group of people, if I do a good job, then the incidence will go up. The incidence of that disease will go up. So it looks like that more persons may have it, but it may be because I've been doing screening in that area, in that population, because then the more persons are found who actually have the disease. Screening, we look at reliability, so we have to consider the precision of the measurement. Do we have an instrument? How precise is that instrument? How precise is that measurement instrument? It may be, a questionnaire. It may be some type of test that is, medically advised or medically evaluated. We look at the measurement's consistency and the repeatability. Is this consistently, can I get the same type of measurement and the same type of response among a similar population? The validity is the measurement really measuring what we think it is, how exactly. And this is measured, this validity is measured by sensitivity and specificity. Specificity, that's a difficult word to say. Sensitivity quantifies how accurately the test identifies those with the disease or condition or trait. These are your true positives. Your specificity indicates how accurately the test identifies those without the condition or the trait. These are your true negatives. And so what you're trying to do is look for people who most likely have the disease, the positive predictive values, the proportion of persons with positive tests who actually have the disease. So your screening instrument, those are the ones you want to look for instead of the negative ones who are the proportion of persons with a negative test who are actually disease-free. So you hope to, make a nice balance between, being able to positively predict, persons who have it and negatively predict the persons who don't have it in order to have a valid and reliable screening instrument. And we know some of those, like I said, colorectal screening, sigmoidoscopies, which is was much more invasive than colon screening, mammograms. We know that these are reliable and valid tests for screening. And there are others too, like depression screenings and other instruments, psychometric type instruments that can be used, questionnaires that can be used to measure specific for specific traits or disease processes among the populations. Some other basic methods in epidemiology are sources of data. These are routinely collected, could be routinely collected data like census data, vital records, surveillance data. Maybe that's all we're studying. It could be that data was collected for other purposes like medical records, and we go back and study that and see what, look for traits and clues that something is going on, trends and traits. The original data could be collected specifically for the epidemiologic study. So it could be the original data. And then rates can be adjusted for age and some other things. We're not going to get into those. Comparison groups are to help decide if the rate of the disease as a result of a suspected risk factor, and then compare it to the exposed group with a group of comparable unexposed persons. So this is typical research where you have a control group and then you have a group that is exposed to an intervention to see if that suspected risk factor, and it would be set up such that you're not exposing somebody to a disease process, but persons who are likely to be within that group. Descriptive epidemiology. It shows a picture of how things are or have been. So, descriptive, you can be, that's like your data that you would fill out in a typical questionnaire prior to research. You would be looking at some questions about the person, their race, their sex, their age, education, occupation, income, and marital status. I mean, those are pretty generic type descriptive factors that we would look at when we're doing epidemiology. We also may look at the place to examine geographic patterns, weather, location, and other factors. In time, we may be looking at at different trends, looking at different points within an epidemic. Are there cyclical time patterns such as seasonal fluctuation? We know that February tends to usually be the peak of flu season. Are there calendar events? Does it relate to when I lived near University of Florida? Always typically flu season did increase, but it was usually earlier there because kids came back, students came back from traveling around the world, and they would come back, and influenza would begin as soon as the students got back on campus generally. Were those related? Were those factors related? And what other type events might be related to a trend or to a trait related to epidemiology? Analytic epidemiology is looking at cohort studies. We might look at current people, prospective studies, or we may go back and look at retrospective studies, things that have already happened. Case control studies, where we're looking at the odds and ratios. We want to look at the how and why of observed patterns within health disease. So cross-sectional studies look at prevalence. There are prevalence studies looking at the frequencies, and ecological studies bridge descriptive and analytic type epidemiology. And clinical trials, these are your gold standard. This is always the strongest measure of research that is possible to produce, to examine and produce findings. Because of randomization to the groups, people are chosen randomly, based on specific factors. It may be every third person, is chosen, or something like that, so that it kind of moves out of the way the idea that there might be some coincidence involved with this. Masking or blinding of treatments. The investigator, they want to make sure that that they are doing everything that they can to make sure that the studies are valid and rigorous in order to have good research. And then there's such a thing as community trials, where entire communities are examined. Statistical associations related with causality. Something that we need to think about with that is bias, and that is the way that they're looking for confounding factors. It looks at a selection, or the way that subjects enter into a study, and also misclassification of subjects once they are in a study. So the criteria has to be set up front prior to the person coming into the study, whether we're doing, going back and looking at charts, and we choose, a specific sample based on specific criteria. And that has to be you cannot change that in the middle of a study. And they're looking for confounding factors, or, factors that might be some type of extraneous event that might somehow influence the study. And applications of epidemiology and community-oriented nursing. Some examples of nursing positions that might use epidemiology would be a nurse epidemiologist, somebody who might work for a public health department, or somebody who might work for the CDC, or other company. School nurses, communicable disease nurses, environmental risk communicators, hospital infection control nurses, and all nursing documentation on patient charts and records is subject to becoming a source of data for epidemiological reviews. And that is the end of Chapter 9.